Great.
Okay.
Thank you.
Thank you. Thank you, Chantal. Okay, so the TRIP project is Treatment Readiness Induction Program. It's a completed study. Okay, there we go. It focuses on addressing some concerns that we know from the field, and we also know from focus groups that we conducted with youth, parents of youth, and the counselors that were a part of the treatment programs that we recruited for this project. There is a disconnect among these youth in wanting to change and investing the effort to make changes happen. Avoiding discomfort, they're embarrassed about their substance use and talking about the sensitive issues that are related to substance use. There's a lack of problem recognition around the substance use, which is obviously a precursor to requesting desire to get help and being thoroughly engaged in the treatment process. And along with that is, because that problem recognition isn't there around substance use, there is errors that go along with adolescence around judgment and decision making. They tend to not engage in the more complex analytic thinking and banking repetition in actions and pulling from that repetition of good behaviors and good practices for the situations that are more impulsive. So they tend to not have more of that analytic thinking. They lack that systematic planning and organization, problem solving. When they're in the moment, everything is impulsive, and they consider themselves invincible. Nothing new to us, especially those that have adolescents in their home right now, especially. And then relationships. So they, adolescents, whether they're juvenile justice involved or not, regardless, they value the peers and what the peers are thinking and what they perceive their peers as doing, whether it's faulty thinking around substance use as a norm or just a rite of passage, or and then they're influenced by their peers. But on the flip side of all of that, the counselors have this great opportunity to promote engagement and retention and positive outcomes. So with all of that brought together, the TRIP intervention is it's 90 minutes, 8 sessions. It's received for this study in residential treatment. And so the adolescents start this process in the first weeks of their care. And it is based on both experiential, some more communication intensive practices, as well as analytic, which is more like school-based. So we'll talk a little bit about what that involves. One component of the TRIP intervention is something that we have built largely off of for some future projects. That's the downward spiral, originally created for adult populations and converted into an adolescent format. So they basically, it's like the game of life where they roll a die and they move to wherever that dice tells them to do. They pull a card, and the card, like the example that's on your screen, which is more of a health outcome, has on a scenario, has points lost that they tabulate on their score sheet, and then a fact or a notable quote. So those are 2 of their 90-minute sessions. They also have 2 sessions on mapping, where in this particular case, they present a snapshot of a problem. So they've been asked to draw out who are some negative friends in your life and what are you going to tell them. You're trying to break those friendships or disconnect from those friends. What would you say? Why are those friendships not good? And then on the flip side, what are some positive friends? So they're drawing out these relationships and seeing them graphically. There's 2 sessions on nudge, which is more of a way to think around what is in your environment, what is a part of your life that's a stimulus, either negative or positive, trying to get away from the term triggers, because youth are, they hear the trigger all the time, and to them that's always negative. Nudges can be positive or negative, or take a negative like a tattoo on their arm and turn it into a reminder of, okay, I'm a big brother, I need to make good impressions on my sister. And every time I look down at my arm and see that tattoo, I'm reminded that what I do is an example to my sister. So the work it is a component that I really do want to focus on, because this is a piece that we've integrated into our other two projects that I'll be talking about. So work it is where they are presented in 2 of their 90-minute sessions early in treatment. What are some of the problems or issues? For example, a problem of trying to decide, do I stay in residential care or do I leave? Or third option, do I minimally engage? I stay here, but I don't really participate. So, and then who's affected by those decisions? Who can help with those, with making an informed decision? And based on those 3 choices, what are some of the good things? What are some of the bad things that might come from those decisions that you make? In reference to rating it, how am I going to feel 10 minutes from now on those 3 choices?
Then where did it go? Why are you yelling at me?
This is the new reality of all working at home, but I'm going to ask everyone who's not presenting to please mute yourselves. I also have a dog barking in the back, so I have to keep muted. Thank you all.
So they are taken through this process about decisions, and it's more of an analytic approach to think around problem solving. And we're hoping that in this repetition, they do it about 5 different times, going through the entire work it process and thinking through how they're going to make choices and decisions that, with this repetition, hopefully they've built in some of more of that analytic, cognitive, more deep thoughts. And so when they're in a critical moment where they would on the other side be more impulsive, that hopefully they can pull some of these quick thoughts, some of this process. They're not going to pull out their worksheets, obviously, but they hopefully will have some of these techniques banked in their brain that they can pull from when they're in the moment. So this design was where it was a sequential comparison, where in each facility they started 6 months of looking at, where we were documenting through assessments what's a typical client's level of motivation as they go across time from baseline when we first recruited them at intake to the treatment program, and then at 45 days into the treatment. So how does motivation change? How does their level of engagement change? Just in normal standard care. And then for each of those facilities, about 6 months in, after baseline phase 1 period, standard operating procedure, we trained the staff on the TRIP curriculum, and then we followed the staff as they were implementing in their facility for another 6 months as they ran 6 consecutive cycles of the TRIP intervention, just to see, again, the effect of our TRIP intervention on, again, motivation and engagement. Some of the outcomes have been reported in studies. Some colleagues are even on the call today. So as compared to the youth receiving the standard operating procedure, the TRIP clients, they improved in their decision making, they improved in their motivation and personal change around treatment and desire for getting help. They also reported significant increases over time in self-awareness and positive self-talk, so turning some of those negative triggers over into positive nudges. And how we can consider our environment to be reminders of remaining clean and not using substances. and on the negative effects of drug use. In a similar study, as a part of the same TRIP project, we worked with 2 facilities that were juvenile justice based, and in those 2 facilities, we were able to really hone in on how TRIP affected their treatment process. We saw in those settings that they showed significant gains in problem recognition, desire for help, just as we found in the residential treatment in the communities. They were also 3 times more likely to want help for emotional problems and 4 times more likely to want individual counseling, all of which lend itself to the fact that they were starting to recognize some of the issues that they wanted to start dealing with. I'm going to transition over to the StaySafe project, and hopefully I'm going to try to move more quickly. I get so excited about this research that I need to watch my time so that we have moments for questions at the end. So as a part of the StaySafe protocol, again, this is looking at adult corrections. In this project, they were programming to address HIV and hepatitis B and C, which are mostly lacking in clinical approaches within corrections, adult correction settings. So that programming is essential. So this project, with colleagues on the call again today, we created a 12-session decision-making tablet app. So took a lot of what was created from the work it, so that what's the problem, who's affected, what are our options, let's rate it, and then knowing what the solution is, taking that work it approach that was group-based in the TRIP project and putting it more into a tablet format to respond to health risk needs around HIV and hepatitis. So as many of y'all know on this call, but just to be deliberate and say it, there are definite benefits to telehealth. A lot of benefits that we're going to be learning in the coming year, I'm sure. But what we do know is that they can be self-administered. So in these correction settings around sensitive topics, like talking around health risk, HIV, getting tested, having self-assertiveness with your partner, around safe sex, that those are conversations that probation officers, they may be having, but they're very uncomfortable having and may not do on a regular basis due to other priorities. So tablet-based interventions are extremely wonderful for corrections and for sensitive conversations. And they also lend themselves to repetition. So a client can retake or start over a session or to repeat it. So these 12 sessions were administered across 3 months. The topics ranged across time in 3 categories. So what are some conversations that you might have with or experience with the people in your life around HIV? So my partner has HIV, now what? And asking a partner about his or her HIV testing. How do you go about doing that? What are some options? What are some places, returning to an old neighborhood? What do you do in those circumstances? And then things, fear of getting HIV testing. So building off of the previous TRIP intervention, the work it approach was adapted into this tablet format, of which you see sample images on with the screen. So what's the problem? Well, it was presented to them in one scenario that they might have chosen. So one of the scenarios, it's hard to ask a partner about his or her HIV testing. Have they gotten tested or not? And what were the results? So, who's affected by having this unprotected sex with a partner? Well, myself, my family, friends, my partner. And so they get to look at and click on each of those options to see some considerations around who would be affected. They're introduced to a slide on who can help. they're asked to choose one person and then to carry that consideration for that one person built into their scenario as they go through the tablet intervention. So they're asked to pick 2 options. There's 4 options that are displayed on the screen. They're asked to pick 2, and then they're going to consider how those 2 options are considered to be good things or not so good things. What would happen based on those options? What would their helpful person that they had selected say about those options? So this study is a little bit different from the TRIP intervention. The TRIP intervention, again, was that sequential comparison where in a residential setting, the counselors were the ones providing the intervention. And it was important for us to do a sequential one where we started with a standard operating practice where they had not been trained as clinicians on TRIP, and had all of those clients prior to TRIP intervention be the standard operating practice, and then introduce TRIP, and then all the youth following TRIP training with the clinicians were considered the TRIP condition. We had to do that because of contamination effects with the counselors being the practitioners doing the study. In this particular tablet-based intervention, you have a little bit more flexibility. You're able to do a true randomized control trial in the sense of some of the adult probationers in this particular case received standard practice, and then so they mostly received assessment for this particular study, and then the other sample received the 12 weekly sessions of the intervention, and that was a random assignment. These were community-based corrections departments and then residential probation treatment facilities. So as those residential treatment were largely individuals that were released from prison and as a transitional setting brought back to their local community, given residential treatment at a secure facility, but closer to home. And then they were tracked on the changes that we'll talk about at 3 and 6 months later. So the participants, they were willing to participate in this tablet-based intervention, even considering the fact that there were multiple barriers for the individuals that were back at home. They had a lot of other demands on their plate, but they were willing to take the time out to do this tablet-based intervention and enjoyed the process. We saw significant improvements in their knowledge and their confidence, motivation around the topics that they were introduced to, including HIV and risk behaviors. And we especially saw the benefits and the increases among the individuals that completed more of the 12 sessions versus less. And the StaySafe participants reported behavior changing. So they were more likely to have HIV testing. Consider how their choices, what are their choices around lifestyle issues and risky sex and having tough conversations with partners. So they were able to work in a lot of what they learned in the sessions into their daily life. A supplement to that particular StaySafe project that's pertinent to the third study that I'll talk about in a second is a women's health supplement. In this particular supplement, again, it's using women as research participants who are on probation in Texas residential treatment sites. This was a 6-session intervention, and they largely they had multiple themes that they could have selected from, but one consideration that I want to point out for the purpose of this study is that among the transitional age women, so again ages 18 to 29, of all the topics or themes that they could have chosen from, the most interesting and relevant to their life that they wanted to learn more about and consider the options around was the protecting their unborn child from HIV. So that's something that we're going to need to build in to our study on adolescents. With that being said, I want to go ahead and move us over to the third study that I'd like to talk about. And this is in R34. Danica Knight is on the call today. She is a multiple principal investigator along with myself. And R34 study that will go, the intervention, the assessment package, the protocols are all being developed right now with consideration from the TRIP intervention that I talked about and the DRR study, and building off of both lessons learned and research off of those studies and integrating them, hopefully more, to the best that we can to be beneficial to the juvenile involved youth as a part of the study. So what we know among juvenile involved youth is that in most communities, these youth are referred to treatment outside of juvenile justice system. So if a youth is on probation, they are not going to, in most cases, receive behavioral health services around substance use as a part of the juvenile justice system. They're going to be referred out to receive those services. And being in line with that, there are linkage and coordination challenges. And those challenges range from the gambit of the probation officer not trusting the services that they might be receiving in the community. How's it going to affect my client? Are they going to receive good treatment? What is that even like? And then for the youth, even when it's mandated, it's hard for them to initiate services because of a lack of a denial, which we've talked about, a denial around having a problem in substance use, that it's a norm. The parents don't see it as a problem. The parents feel like this is my child's issue. They need to take care of it on their own, and getting them to treatment is not a priority for them. So that linkage and that coordination to external services is really challenging for youth on probation to get those services. So we need to build in opportunities for these youth until they are accurately and wonderfully linked to external services. What can we do in the juvenile justice settings to help address problem recognition and motivation around services while they are still under supervision? And we know that the probation officers, as we talked about for adult corrections, that talking around sensitive issues, risky sex, and having assertive conversations with partners, and HIV testing, that those are they're important, very important to probation officers, but they are having to deal with a whole lot of other issues. And those are sensitive topics that would take them in a different direction away from the community supervision in terms of probation that they need to talk about when they have moments to interact with their youth. So we need to find ways to help these justice staff with addressing these sensitive topics. So the SUHRI project, Substance Use and Health Risk Intervention, is the intervention that we're developing right now. We'd like to develop it and test it using a technology-based approach, very relevant to today's age, where we'd like to promote motivation and information around healthy choices. Some of those choices and those conversations would be strategies for better substance use decisions around sexual health risk, substance use, and relationships. And then motivations, going back to the enhancing what may not even be there around problem recognition and intentions to get help or be engaged in substance use care. We're hopeful that this intervention that is created, that is a tablet-based approach, a technology-based approach that these youth can receive while they're on probation. It's self-initiated. They're not having to have a practitioner informed conversation with a probation officer, that they're going to have repetition in these sessions, that all of this will lend itself to making behavioral skill development and behavior change around better choices around substance use, risky sex practices, and exploratorily around service initiation. We'd absolutely like to see that as an outcome. This particular protocol is similar in many ways to the DRR project. We start with an intervention feasibility phase where we're going to do focus groups and theater testing of our tablet. We want to make sure to bring key stakeholders to the table early on. So representatives from staff that are in probation officers that are in correction settings. Ultimately, they will be the individuals once we're done with the study and found, hopefully, fingers crossed, found that this intervention is effective. The probation officers will be the ones that are picking this up and using it, and learning from what they feel these motivations are and what conversations they're already having around risky practices and what conversations they're not having, and help integrate that into our study. And then talking with the youth, what's relevant to them, what's not. So introducing a lot of what we've developed in the TRIP curriculum and a lot within the DRR and presenting it through a tablet-based and getting impressions during the pilot phase of intervention feasibility. And then taking that over into our study feasibility phase, where we're going to have two conditions. Both conditions in our case for the SUHRI project are going to be receiving a tablet-based approach. One is going to be the interactive approach, where they're going to go through the work it, what's the problem, who's affected by this, who's my important person, what are options for solving this problem, how am I going to rate it, how is the helpful person going to rate this. They're going to receive that. They're going to receive a virtual tablet-based downward spiral game, that Monopoly-based game about the longer you play, the more consequences you're gonna tabulate off of your score sheet. So what are some consequences to substance use? So they're gonna receive that in the tech intervention for the individuals that are randomized to receive that condition. For the youth on probation, for the facility that we're working with, that receive the information only, they're going to receive the same sort of information around health risk and sexual risk conversations, but it's going to be information. And it's going to be videos created by NIDA, or videos that we've taken from the CDC on these health risk topics. So it's going to be the same amount of time for the youth, but it's going to be more information based. The selecting options, thinking through and typing in what the consequences are based on different choices. They're not going to have that. It's going to be more information based, which when you think about it, when you go to the doctor's office and you're there to talk about a general physical checkup, but you want to know more about this sensitive topic and you don't want to ask them, you go to the wall and you pick up a brochure. So it's going to be that same approach in the information only condition, except they'll get more information than would be in a brochure. And then we'll check with them and see what their changes are at 3 months and 6 months post intervention. So the potential impacts of this particular study, we hope are pretty sizable. If successful, the SUHRI project will serve in a broader juvenile justice case management and service delivery approach. So this will be where the probation officers in the future, as they're introducing the SUHRI tablet-based approach into their settings, that this will help them in their regularly scheduled supervision meetings, whether those meetings are on the office, at home, virtually, which we're seeing a lot of virtual conversations right now with the COVID. And then ultimately with the SUHRI as a web-based approach, we're hopeful that these probation officers will be able to really hone in on these risky sex practices and be able to make referrals that are appropriate to address these risky practices to providers that can have more conversations around substance use or around HIV or around STIs or whatever is pertinent to the youth. So appropriate referrals will be a nice way to build off of the tablet-based intervention and what the youth are experiencing through that platform. So I'm going to stop there. We're about 20 minutes left in the hour. And I want to thank y'all again for this opportunity to introduce a lot of the work that we're doing among juvenile involved youth here at the Institute of Behavioral Research Institute at TCU. And I'm gonna leave this back to Jose. I can take time to answer questions, or whichever approach we want to go from here.
Thank you so much, Jennifer, for such an interesting set of studies and such an important population. And those of us who work with the population know how difficult it is to work with this population. So truly appreciate Danica and you
Absolutely.
taking on this amazing challenge. So I wanted to ask you about your last statement about the probation officers being able to talk about more sensitive questions. Do you mean that they would do that by giving the tablet, or that they themselves would be able to talk about more sensitive questions? And if so, what kind of an intervention are you using with the probation officers to help them?
So for this particular study, we, as a part of the R34, will have RAs that are administering the tablet, and so that's for the effectiveness or efficacy trial phase. But if we find that the SUHRI intervention is effective, then after that, we'll be able to, with everything through NIDA, be able to make this intervention accessible through to probation officers to be able to pick up. So they would use the same tablet-based intervention that we've created and worked with through the effectiveness trial. But my hope is that as a youth is completing the tablet, that at the end of each of the sessions that they interact with, that there's going to be a summary slide. And on that summary slide, it's going to say, based on the interest that you expressed during the session, based on the concerns, the options, the answers that you provided, that here's some referral, not to particular providers in a part of the platform, the tablet, but you know, as a youth, you may need to consider seeing a healthcare provider on this particular issue, X, Y, and Z. And so that summary slide would be a nice jumping off point for youth. We can prime the youth to say, okay, at your comfort level, mention some of these concerns to your probation officer, because then the probation officer can provide direct referrals to specific behavioral health counselors, clinicians in your area to address and get deeper in these conversations.
Thank you so much. So I'd like to open it to anyone who has questions. Anyone who would like to ask a question? I've never seen such a quiet group.
This is Lisa. I don't have a question. I just wanted to thank you so much for that great presentation. The breadth of the work you're doing is just so impressive, and it's so important. And you're addressing such significant topics with young people. Thank you for sharing this with us.
Absolutely. Thank you again for this opportunity. It's been a pleasure to create this presentation and to share it with our group that addresses youth needs. And I know lots of folks on this call do a lot of great work, and hopefully we're making a difference together.
Jennifer, this is Alan Budney. Also, thanks a lot. I was wondering if some of the tools that you use in your sessions for TRIP, etc., are available for use and exploration.
Absolutely. Thank you for your question, Alan. So on this slide on the website, the www.ibr.tcu.edu, which is at a link at the very bottom of the slide, you'll be able to go in to the projects or interventions tab and be able to pull up the entire TRIP intervention. And so that is available. That intervention, that project wrapped up a few years back. So we've had an opportunity to really complete the study, do a lot of the effectiveness write-ups and publications. So at this point, we're in a position to make it available. We have made it more widely available for other projects that we have underway. The downward spiral is very well used among juvenile populations. We've had rightly so, a very large request of downward spirals recently for corrections settings. Good way to fill the time for individuals that are in correction settings. So TRIP interventions on there. When the SUHRI project is complete and we're going into our R01, which we hope to do following this procedure, that hopefully will be available. We try to make everything public access to make bigger impacts. And feel free to Alan to reach out to me on anything that I've talked about today, and I can be able to provide a direct path to those
good
resources.
To hear so many people are using it. It's excellent.
Good.
Yes. Anyone else? So I'll jump in because I have some other questions. Jennifer, I know that in some of these early studies you've used 3 and 6 months follow-up. I'm assuming that's 3 and 4 and 6 months after the completion of the intervention. Do you have any sense, maybe from theory, of what would make this a lasting change?
So we have had studies where we have longer durations for residential settings that youth have longer terms, average terms of stay. We've been able to look at the outcomes from the TRIP intervention at 12 months and be able to see some preliminary effectiveness around a sustained engagement in the treatment process and sustained decision making. Our samples go down as most projects at that point. So we're always looking for opportunities to do the long-term follow-up. And it's especially challenging in the field when we're doing probation or parole, community-based follow-ups. The reason why we're doing 3 and 6 is because it's really hard to find these, to locate the youth and get them engaged, even with small amounts of compensation for their time. But in reference to your question, yes, we have been able to look at the TRIP effectiveness at 12 months and be able to see some positive, sustained effects.
Thank you. And I have another question. In you have different components to the intervention, and then and each one is tackling a particular mediator. you know, either recognizing the problem or being more analytic about it. Have you thought of doing studies where you would look at what you get from each of those components of the intervention separately as well as together?
Absolutely, yes. So for example, around the TRIP intervention, we looked at motivation was one of our studies, and that was published in JSAT, Journal of Substance Abuse Treatment. And as a part of that study, we looked at the DiClemente stages of change. So the interconnection between problem recognition, desire for help, and treatment readiness, and found that that the DiClemente's process held a reference to treatment, the TRIP intervention. So the individuals that improved the most in the TRIP intervention around some other like positive impulsivity and improving their level to think more clearly, more rationally in the moment, that when looking at urgency, positive or negative, that for the youth who had problem recognition, that they needed to have that first to be able to have the biggest bang from the buck from the TRIP intervention around urgency and impulsivity. And so that was a first step. For those that had problem recognition or just desire for help, but not the problem recognition, it wasn't the same for them. So, so the first step for the youth is recognizing that they have a problem, and then moving from there.
Thank you. It's really interesting how thoughtful you've been and really consider all of these various aspects of both sustainability and mediators. What intervention has what impact, and how does it contribute to the whole outcome? Right. Anyone else would have a comment or a question? Jennifer, do you want to say some final words?
Well, I thought of one other mediator, so that I was excited to find as a part of our research, which lends itself to more of the tablet-based approach, which is the experimental side. So what am I trying to say? More of the engaged, so the downward spiral. So the youth that participated in the downward spiral games at the beginning of their treatment process or did the mapping components, that those were the same youth that had more effects than the youth that started with something that was more of like the work it. So the work it is more of like a deeper analytic thinking. So the youth didn't respond as well to that and the outcomes that they were experiencing from their intervention as much as the individuals that started with the downward spiral game-based, highly engaging approaches. Those are really what makes the biggest impact on youth.
So do you mean that the downward spiral creates the motivation to then profit? Yes. From the more analytic?
Yes, the downward spiral really hones in on that problem recognition and seeing what are the consequences of my actions, how do they affect other people, and that is one of those very first things that you have to get to before you can start doing more of the deep analytic schema-based approaches where you're doing more of like the schoolwork and thinking about options.
Yeah, that kind of sequence is very important to identify. What you have to do to create that readiness for the next stage.
Right.
And inexperienced clinicians or counselors always want to go for that change component before preparing the client to be able to profit from it.
Mm-hmm.
Well, thank you so much. This has been an amazing presentation coming at a time like this when, I don't know about you, but I just read too much of coronavirus news. And it's nice to come back to the world that interests me the most. Thank you so much.
You're most welcome. Thank you all for taking your time out of your day too.
Thank you.
Bye-bye.
Thanks, Jeff. Thanks.
Okay. Bye.
Bye.